fourth-year medical student as well at the University of Minnesota. And I chose to talk about hypertension disorders in pregnancy, and specifically focusing a little bit more on HELLP syndrome. I chose this topic because I'm going into family practice. I think that pregnancy is one of the most happy and exciting times in a lot of people's lives. However, if complications happen, it's also one of the most sensitive and scary times. It requires a lot of collaboration between critical care, OB, maternal fetal medicine, pediatrics, all different groups in the hospital. And I've seen some patients with hypertensive disorders, and most of my training was in a rural site, and so they oftentimes came to sites like Ridges or Abbott or other places where they had access to critical care units. So kind of an outline for this talk. I'm going to talk a little bit about pregnancy and the physiology, just because when we care for patients, we have to think about all the systems and how they're working together. Go over some of the hypertensive disorders in pregnancy, and then I'm going to focus on HELLP syndrome, and then research and future ideas, directions. So, the human circuitry. One thing that I think is really cool about the human body is that it all goes back to physics. When I took physics as an undergrad, I didn't believe I'd ever think about it again, but we function, our pressures function on basic physics principles. We have resistance in our vessels, and then we depend on the flow. Without going into too much detail, pregnancy really alters that, because when you have a infant or a fetus that's attached to a placenta, you're adding an extra organ system in, you're changing the dynamics of the blood flow. That being said, adding an organ adds an organ in a parallel system, which causes the resistance of the vessels to drop. So overall, the total peripheral resistance during pregnancy is thought to drop as much as 40%. So that's a pretty significant difference. There's also, because of this, there's an increase in the circulating blood volume to support the cardiac pressure and make sure that all the organs, including the placenta and the fetus, are being well perfused. Without that increase in blood volume, pressures would be significantly decreased, and be a lot of problems. But because of that, it does result in a physiologic anemia of pregnancy. It's something we monitor often in clinic, just because the red cells become diluted. So it's not uncommon to see. And then at birth, with the loss of the placenta at delivery, usually the maternal resistance goes back to normal pretty quickly. In addition to increasing the blood volume, the body also compensates by increasing cardiac output. And how it does that is by increasing the heart rate. So usually mothers have, their baseline will be a little bit higher than what they would be in a non-pregnant state. Bottom line though, taking all these things into account, pregnant women usually do have lower blood pressure than they would when they're not pregnant. That vasodilatory change of both the hormones of pregnancy and then the changes in the peripheral resistance kind of lower the baseline overall. The reason I'm emphasizing this so much is it is very strange to have hypertension in pregnancy when you should have all these natural things making you tend towards hypotension. A few other pearls that we won't go into as much. Pregnancy usually results in a hypercoagulable state. It's thought to be a kind of adaptive mechanism because women bleed when they give birth, and so being a little bit more hypercoagulable results in less blood loss, less complications in the long run, so bodies adapt naturally. Thought to be an increase in fibrinogen and thrombin, and then a decrease in protein C. So the fibrinogen and thrombin helping with clotting, less protein C, which is usually has a blood thinning effect. One other thing pregnant women have is usually an increase in minute ventilation, and that's to help blow off excess carbon dioxide. Usually women are in kind of a state of a respiratory alkalosis when they're pregnant. And that's just, again, the fetal CO2 and helping compensate for that.
I've always heard the pregnant woman is eating for two. Now she's also breathing for two.
Exactly. So when we think about pregnancy, there's complications, and the deadly triad is hemorrhage, infection, and hypertensive disorders. I'm not going to go into the first two as much, but they contribute most greatly to maternal mortality and morbidity rates. These three are like 80 to 90% of like maternal death rates. And so, yeah, infection would be something like chorioamnitis or endometritis. Hemorrhage would be blood loss from procedure, things like that. So, hypertensive disorders in pregnancy. So, according to the World Health Organization, 16% of maternal deaths are attributed to hypertensive disorders. It's a little bit lower in the United States. In a 2-year span from 2011 to 2013, approximately 7 to 8% of all pregnancy-related deaths were caused by hypertensive disorders. Probably much of that is lower death rates just because women here have access to, a lot of women here, not everyone has access to prenatal care, regular follow-up with their doctors. But hypertension in pregnancy is defined as blood pressures greater than 140/90 after 20 weeks. If women are hypertensive before 20 weeks, it's thought to be a usually like a chronic hypertension during pregnancy. So sometimes women do have baseline hypertension before that, and it's not considered one of these disorders caused by the pregnancy. As far as treatment, labetalol is usually the first line to treat hypertension in pregnant women, followed by hydralazine and nifedipine. Typical renal drugs that work for blood pressure, such as ACE inhibitors, ARBs, diuretics, are all contraindicated because they affect fetal renal function. So we don't like to give those. And screening and follow-up is key. So that's why women come to clinic. They get their blood pressure checked every time. One hypertensive disorder in pregnancy is called preeclampsia, and that's thought to occur after 20 weeks at gestation. Usually you see it closer to term. There's a lot of uncertainty as to why and who gets preeclampsia, but it's thought to be originating out of a dysfunction in the placenta itself. Thought that basically anti-angiogenic factors cause widespread endothelial dysfunction. That results in an increased vascular permeability, the blood vessels vasoconstrict, coagulation cascades are activated. Risk factors include, usually you're actually more likely to be diagnosed with preeclampsia if it's your first pregnancy, but if you've had a previous preeclamptic pregnancy, you're more likely to have another one. But preeclampsia, there's two things right away that you think of. Blood pressure over 140/90, and then a 24-hour urine protein that exceeds 300 milligrams. And then in the absence of that, there's other kind of softer characteristics such as edema, significant like peripheral edema, impaired renal function, thrombocytopenia. And preeclampsia is more common on women who already have hypertension.
I got a question for you, because I'm not far from an expert on this, but it came to me, and I think it's very interesting. No, it's correct or not. But so you always say pre-eclampsia.
Mm-hmm.
What's eclampsia?
Eclampsia we will talk about in a little bit.
That's good. Just getting warming up.
Yes, we're just warming up. So, yeah, it's good. So the diagnostic, this is from a kind of a big pamphlet from the American College of Obstetrics and Gynecology. And so there's a diagnosis for preeclampsia, and then once the blood pressure gets higher, it's defined as severe, or preeclampsia with severe features. And that's blood pressure with a systolic over 160, diastolic over 110, thrombocytopenia, impaired liver function, progressing to renal insufficiency, edema, just all these much more severe systemic effects. Treatment for preeclampsia is delivery. There's really not much else you can do. You can put mother on bed rest, but there's no medication that's going to take it away. So after 37 weeks, if a woman comes in with preeclamptic features, she's probably going to be induced or delivered by C-section really quickly. Depending if baby is stable, looking well, usually, and head down, will be induced for a vaginal delivery. If there's other reasons, maybe a C-section. Before 37 weeks, this is kind of a shared decision making between the physician and the mother, as far as keeping the mother on bed rest, doing a couple doses of steroids, and then delivering in 48 hours if they're concerned about fetal lung maturity. And then at that time, blood pressure control using that labetalol, hydralazine, nifedipine, and then seizure prophylaxis. We'll talk about that in a little bit as well. Because if preeclampsia is untreated or inadequately treated, it can lead to eclampsia. So eclampsia is kind of the subsequent convulsive stage that comes after preeclampsia. So basically, presence of the onset of a grand mal seizure in a woman with preeclampsia.
I hate those.
Grand mal seizures?
Yeah, in the intensive area.
Yeah. So prior to seizure, it might have a headache, changes in vision. Usually women with preeclampsia don't feel well anyway. The few women I've seen have had just a lot of edema, say they're seeing stars, things that are kind of red flags. Also might be hyperreflexive or have clonus. So things to look for that are easy to do on exam. And usually a preeclamptic seizure needs to be antepartum, so kind of prior to onset of labor, intrapartum, or 48 to 72 hours postpartum. If it's after that, them calling it eclampsia, you want to look for something else at that point. Treatment. Oh, I was going to ask if anyone knew the treatment, but it's magnesium salt. Oh, sorry.
They do. I think some of them know this.
Yep. So, and that's kind of
boatloads of magnesium.
boatloads
Not just
of
a small
magnesium.
one, lots of magnesium.
And that's like board's question. Like they'll ask you. So, yeah. Yep. This collaborative eclampsia trial demonstrated that magnesium reduced the risk of seizures in women by 52% compared to diazepam or phenytoin. You can use those like if the magnesium doesn't work, but you hit the patient hard with mag. The mechanism is still a little bit unclear. Thought to trigger cerebral vasodilation. Also thought to kind of block the neuromuscular synapse, altering the neuromuscular transmission as far as convulsion.
Such an interesting electrolyte. We use it so frequently for, what's that one heart rhythm we use it for? Torsade. I know our ICU nurses know right away, recognize Torsade and treat it with mag. Works good for people with atrial fibrillation. And people aren't taking it on the street now, they take it orally, right? Something called Calm, isn't that right? They'll take magnesium just to help them feel better. I don't know what, it also makes you poop.
Yeah.
Anyway.
Yeah.
That's what makes you feel
Makes
better.
it tricky. I don't know.
Check out.
So regarding mag, you can see the serum concentration. The literature I saw say up to 7, and if you see a mag of 7, that's usually pretty strange. So usually you give a 6 to 8 gram loading dose intramuscularly plus a 2 gram per hour infusion. You can also give like a fast, like 15-minute infusion of mag, and the dose is a little different. I think it was like 6 or something. So then with that mag, you can see areflexia. Other things, you do get, there are cardiac concerns. There are those occasional case studies of women going into a abnormal rhythm just due to the electrolyte imbalance or arresting.
Don't overdo it.
No. So risk outweighs benefit is kind of the bottom line. The World Health Organization has a list of medications that they deem essential for any hospital, and magnesium is on that list for this reason, because if a pregnant woman has an eclamptic seizure, you want to get mag in and fast. So, eclampsia in pop culture. The first time I ever heard about eclampsia was from ER, actually. There's an episode in season 1. It's a very interesting episode. I won't spoil it for you. And anyone know what this is? I don't want to do spoiler alerts again, but Downton Abbey, there's a episode about eclampsia too. So, think it's interesting. That's how a lot of people that I know first heard of eclampsia. So
Not pre-eclampsia, but eclampsia?
eclampsia.
Oh, really? Okay.
Yeah. So thank you, PBS, educating us. All right. I'm just gonna get my notes here.
Of course, the best thing ever said on that Downton Abbey was the older gal who said, "All the people here are talking about something I don't understand. What is this thing a weekend?"
No, Donna.
When you're so rich,
Yeah.
you
So
don't
now-
have to know what a weekend is. That's a strange thing.
So kind of the third hypertensive disorder in pregnancy, and the one that kind of makes most physicians' heart drop into their stomach, is HELLP syndrome. HELLP stands for hemolysis, elevated liver enzymes, and low platelets. That is again, another thing that is just
Let's go
tested
over
all
that
the
again.
time. Hemolysis,
Hemolysis, okay.
elevated liver enzymes, and low platelets.
HELLP syndrome.
HELLP syndrome.
2 L's.
Yep. Yep. So
Remember
it's
the Beatles
controversial.
song, that was a good one.
Yeah. It's controversial as to whether HELLP syndrome is the relationship between preeclampsia, eclampsia, and HELLP is debated. From what I could tell in the literature, oftentimes, if preeclampsia can turn into HELLP syndrome, but you don't need to have preeclampsia before being diagnosed with HELLP. And 15 to 20% of patients with HELLP syndrome will not have the hypertension or proteinuria. So just because they don't have those things doesn't mean you're in the clear. So again, thought to be a complication of preeclampsia and eclampsia, though there's some debate. It can occur ante, intra, or postpartum. And usually it's characterized by sudden deterioration in mother and fetus. It occurs in 0.1 to 0.2% of all pregnancies, which, doing the math, is 10 to 20% of all pregnant women with eclampsia, with preeclampsia with severe features. So, it's not common, but in a woman who already is having complications in her pregnancy, you definitely want to have keep your eye out for it.
The problem is, what if you don't measure the liver enzymes? What if you don't measure the platelets?
Exactly.
So this is one of my other favorite things is the anatomist taught me, when you're in the anatomy lab, you see what you look for, and you look for what you know. If you don't know anything about this, you won't think to measure liver function test. You won't think to measure the platelets. You may never see a case, although you're seeing the case, you don't realize you're seeing the case because you never measured liver function test. You never measured platelets.
Yeah. So a little bit of pathophysiology. Again, thought to be some sort of abnormal development and dysfunction of the placenta. They think that it leads to an oxidative stress and ischemia, which then causes the cells to release more cytokines, factors, results in endothelial dysfunction, and the big one is hepatic inflammation, which leads to an activation of the coagulation system, leads to platelet consumption, resulting in thrombocytopenia, and then shearing of the red cells. That in turn can lead to microthrombi, fibrin deposits in the kidney, liver. That'll cause necrosis and potentially hemorrhage and rupture.
Does this remind you of anything, the two medical students, any disease? Yes. It causes 5 things. Pentan,
DSC?
called TTP,
TTP.
thrombotic thrombocytopenia purpura. Thrombocytosis, you see fragmented red cells, so-called MAHA,
Mm-hmm.
and you see low platelets. It's interesting.
Yeah. So HELLP sometimes can occur earlier. It's most often diagnosed in the 28 to 36 week window. Women present with abdominal pain, usually in the epigastric to right upper quadrant, vomiting, nausea, malaise, usually like kind of a history of discomfort like over a few days. Again, it's interesting because that's something that, like epigastric pain, you might think, heartburn with pregnancy, some flu-like symptoms. So it really can be hard to diagnose. That's why physicians really do need, and all need to have kind of a low threshold to work things like that up. Because, as we'll talk, the complications of HELLP are very significant. And then you might see an elevated, particularly ASD and LDH upon laboratory exam. Again, could have hypertension and proteinuria, but not necessarily. So differential diagnosis. One of the other big bad scaries is something called acute fatty liver pregnancy. It's most often mistaken because the presentation is exactly the same. And that's progresses rapidly into liver failure and encephalopathy. So this is the liver, and all that white is fat. So it's not supposed to look like that on cross-section. HELLP may also be mistaken for TTP.
There you go.
And TTP presents with the same thing, the hemolytic anemia, altered mental status.
How do we treat TTP? Anybody here seen it? Do we do it here? I don't know if we do it or not.
Didn't we have somebody that had that recently? Or they were testing them for it?
I had a patient. If you look at the slide.
It's, you know what we do? We do therapeutic plasma exchange.
Plasma exchange. Super.
So it may not be done here. Because I don't know.
Sent them out.
We send them over to Southdale for therapeutic plasma exchange. They have to actually use plasma.
Yeah.
It's the plasma that cures you, not the, because if you just do therapeutic apheresis and remove their plasma, give them albumin back, it doesn't work. You have to take away the plasma and give them fresh plasma from somebody else, normal plasma.
Yeah.
And that is the treatment for TTP.
I think it's kind of hard because as far as, I think with HELLP you're going to have other things going on, but it was like, oh, the LDH is higher in TTP, the platelets are lower, but again, I don't think I would bet the farm on that by any means. So, the disease course. To have a true diagnosis, you must meet all the criteria comprising its name. So you need to have HELLP. You need to have the hemolysis, which you'll see on a peripheral smear. So you see the little sheared cells within these are red cells here, and it's a white cell, but so workup would include a CBC, peripheral smear because you need to see that shearing, the hemolysis, AST, bilirubin. Platelets are going to be less than 100,000. Your bili is going to be greater than 1.2, and your liver enzymes are going to be 2 times the upper limit of normal. So you're looking in the 140s for AST. And you do have to be pregnant. So this is, usually, yep. Complications. So can get DIC, widespread clotting activation, which then results in a bleeding state once you use up all your coagulation factors. Can result in a placental abruption, which is, again, separation of the placenta from the inner wall of the uterus. Painful bleeding, also acute renal failure, pulmonary edema, retinal detachment. You just have this widespread systemic inflammation that occurs. So liver and pregnancy. With HELLP syndrome, hepatic rupture is rare, but probably the most serious, scary thing we think about. It's thought that fibrin deposits in the sinusoids of the liver, so in these sinusoids that are they get blocked. That leads to obstruction, which will lead to hemorrhage, hypovolemic shock. So a liver hemorrhage in a pregnant woman has a 39%. So it requires urgent surgical or IR procedure. And they might be able to ligate the hepatic artery, pack the liver, arterial embolization.
Anybody remember somebody this week who had hepatic hemorrhage?
Mm-hmm.
Our patient, comfort chair now.
Yeah. So it's rare but life-threatening. So it occurs in it was a very broad number. So 1 in 40,000 to 1 in 250,000 HELLP cases. And for every piece of literature I saw said that it occurs in the right lobe of the liver most often. And then you can also have a intraparenchymal liver hematoma or a subcapsular between the Glisson's capsule. So that's here. These are from my notes from medical school. Dr. Nelson from Duluth will be happy that I used his slide.
That's actually useful.
It was, going back, reviewing. Definitive treatment is delivery for HELLP syndrome as well. However, with the other underlying things going on, a lot more is going to need to happen. This is a really sensitive thing to treat because delivery is might be more than 34 weeks. I said it's like that 28 to 36 week window. You have a infant that's going to need quite a bit of medical care as well. Every family is going to approach that issue differently as far as mother's well-being versus child's well-being, what's best for both parties. You're kind of treating, two different patients in itself, and how you look at that is really something that is sensitive. So if it's less than 34 weeks and mother is stable, literature suggests you can wait to administer steroids to help with fetal lung maturity. However, there's literature that argues that even in the diagnosis of HELLP, even waiting that amount of time, you're just risking progressing into more organ failure. So again, conversations with the mom about, what their family mom about what their priorities are. But if you do wait, address the hypertension, consider magnesium prophylaxis so she doesn't have an eclamptic seizure. And so this was a really nice slide I found. So it has kind of, the first step is ensure delivery of babies. And then it says if the patient's stable or unstable. So if the patient is unstable, urgent laparotomy to look at the liver. If it's stable, you can wait, get a CT scan, correct coagulopathies, eventually wait to see if mom recovers. So.
That is scary.
Yeah. So steroids, there's a lot of literature out there. There's not a lot of, it was interesting researching this. There's not a lot of literature on HELLP syndrome out there. I think it's it's rare, and things move so quickly that it's hard to, it's been hard to establish standardized research trials. It's also hard to do research on a pregnant woman in general because it just has this whole other level of ethical issues. So there's a debate as to whether every woman who presents with HELLP should receive steroids. A Cochrane review evaluated 11 clinical trials. It said there was no difference in maternal death or morbidity, but the mother's platelet count improved. So maybe by the numbers better, but overall didn't seem to make a huge difference either way. Postpartum HELLP, so just because infant is delivered doesn't mean out of the clear yet. Until day 3, women run a risk of developing HELLP syndrome, and HELLP syndrome is actually more serious after delivery. It's usually more aggressive and it's usually harsher on the kidneys. And again, steroids didn't really seem to do anything as far as whether rescue blood products were indicated. So I just kind of want to talk about pregnancy in the ICU a little bit. So 200 to 700 women per 100,000 are admitted to the ICU. One of the literature I reviewed suggested a 5-step approach to communicating with intensivists, OB, maternal fetal medicine, anesthesiology, and neonatology. So number 1, differentiate between medical and obstetric disorders. So is this because of the pregnancy and what's going on, or is the hypertension, everything else, some other organ system, just other medical illness manifesting? Identify and treat that organ dysfunction. That's where thinking about the physiology of pregnancy that I talked about a little bit, as far as blood pressure and anemia, all those things. Assess maternal and fetal risk. A lot of medicines that are given are contraindicated in pregnancy, so it's always something we have to consider. Choose mode of delivery if appropriate, and then optimize organ function for safe delivery. So, ACOG pearls, optimizing for delivery. 70% of women who are admitted to the ICU are delivered by cesarean section. If you can, 2 doses of betamethasone to facilitate fetal lung maturity is preferred. Always optimize blood volume status. Discontinue anticoagulation. Avoid platelets, heparin, desmopressin, and TTP. Platelets don't do much in TTP. They just get sheared.
Yeah, don't give more platelets. It's just like adding fuel to the fire.
Yep.
When you have TTP, or probably helps with the food.
I actually had HELP stuck in my head. It was funny that you said that earlier. I had this stuck in my head while I was working on this. So
There.
yeah, so hopefully it was an overview of just kind of basics of hypertension disorders in pregnancy and kind of why we worry so much and how the ICU may be involved in such issues.
So when the Beatles sang that song, that I need someone, not just anyone, what they meant was maternal fetal medicine, obstetrics, and experts in this area.
Exactly.
Yeah.
Exactly.
Have you guys seen one of these?